So now we'll be discussing the different liver function tests as well as some of the enzymes of the liver that indicate liver damage. So your liver function test is also referred to as your liver enzyme test. Elevations in your liver enzymes reflect liver injury or hepatobiliary obstruction rather than actual liver functions. If you want to test liver functions, you need to test your bilirubin, your protime, and your albumin measures the ability of the liver to excrete substances and synthesize protein.
Your ALT is also known as your SGPT or your serum glutamate pyruvate transaminase. It's found primarily in the liver with small amounts in the heart, muscle, and red blood cells. An elevated ALT is the best test for identifying subclinical parenchymal liver disease. And the way we measure for your ALT is measuring for the decrease in absorbance at 340 nanometers as NADH is converted into NAD. For your reference range, it's 7 to 45 units per liter. Next is your AST, also known as your serum glutamate oxaloacetic transaminase. This one is found in the liver, heart, kidney, brain, pancreas, and lung, as well as your white and red blood cells, which makes AST less specific than your ALT. Again, we're measuring for the decrease in absorbance as your NADH is produced to NAD. For the reference range, it's between 5 to 35 units per liter.
Now, let's take a look at arteritis ratio. Normally, your AST to ALT ratio is at around 1. Levels in which the ratio falls less than 1, in which case your AST is normal or lower than your ALT, may be indicative of acute viral hepatitis or extrahepatic biliary obstructions. In cases where the ratio is greater than 1, or where your AST is higher than ALT, or ALT is significantly lower than your AST, this may be a case of your liver fibrosis.
Up next is your lactate dehydrogenase, or just your LDH. LDH is very nonspecific as it's found in most tissue and is less useful than AST and its ALT counterparts. ALT has largely replaced the use for your LDH. However, it's still taken as a chemistry test most often times. In myocardial damage, LD1 and LD2 will predominate, and in liver skeletal muscle disease, LD4 and LD5 predominate. So you have the table on your right shows a summary of the different LD and their isoenzymes, and just below that is the specific or different composition of those isoenzymes. So for your LD1, it's most commonly found in your heart. For your LD2, it's found again in your heart as well. That's why they're both elevated in myocardial damage. LD3 is found mainly in your lungs. LD4 can be found in both your lungs and your livers, or rather it has its highest concentration in your lung and skeletal muscle. And then your LD5 is in liver and skeletal muscle. LD values are highest in newborns and infants, and hemolysis invalidates LD and LD isoenzyme analysis. Hemolysis also affects both total LD and the LD1 to LD2 ratio. So the measurement for your lactate dehydrogenase can be done in the forward method or the reverse. For the forward, we're checking from the conversion from lactate to pyruvate, while in the reverse, it's pyruvate to lactate. The forward one is more commonly used in the laboratory. And then in order to differentiate the different isoenzymes, we utilize electrophoretic separation using an agarose gel. In normal patients, the order is 2, 1, 3, and then 4, 5. However, certain disorders may affect this order. For example, your germ cell tumors in which your LD1 is increased. In your myocardial infarction, we have what is known as a flipped ratio, in which the LD1 to LD2 ratio is greater than or equal to 1. In cases of hemolytic anemia, megaloblastic anemia, and renal cortical diseases, there's also an increase in your LD1 and a flipped LD1 LD2 ratio. In tumors of your WBCs such as leukemias, lymphomas, LD3 and LD4 are increased, while your LD1 and LD2 are decreased. Next up is your alkaline phosphatase, or your ALP. It's found primarily in bone, liver, intestine, and the placenta. The most common elevations are due to bone and liver pathology, with the highest elevation seen in Paget's disease of the bone. Heat fractionation. A serum sample is heated and the activity is compared with unheated serum. And for the reference range, we have there at the bottom and it varies with age. We'll discuss more about heat fractionation in the coming slides. Your ALP is measured using your p-nitrophenyl phosphate as a substrate and an alkaline pH, yielding inorganic phosphate plus the colored paranitrophen anion. You have zinc, which is a component of the enzyme, and you have magnesium and other cations as an activator. Take note of specific anticoagulants present in collagen tubes, such as your ETA, citrate, and oxalate, as these may falsely lower your ALP activity. Activity increases slowly on storage because of the loss of inhibitors, and specimens are relatively stable for up to 1 week when stored at 4 degrees centigrade. We can use your HPLC or your high performance liquid chromatography when separating ALP isoforms. And as I've mentioned on the first slide, you have your heat fractionation. So heat fractionation has been used for many years to determine the source of the elevated total ALP. Placenta is the most heat stable, liver is moderately stable, and bone is the most labile among the three. You have bone burns and liver lives. I guess it's a mnemonic if you want to use. The most common cause of increased ALP are liver and bone diseases. Cholestasis more frequently causes an elevation of ALP than do hepatocellular disorders. But the most common cause of an increased bone isoenzyme is due to Paget's disease, in which there is an increase in osteoblastic activity. Some cancer isoenzymes are uragan, which is found in your seminoma and your gonads, nagao for your pancreas and chlorometastasis, kasahara in your liver and GI tumors, and then the carcinoplacental ALP found in gastric and colorectal cancers. Your gamma glutamyl transferase or your GGT is an enzyme found in the kidneys, liver, and pancreas. In the liver, GGT is located in the canalicular membrane of hepatocytes and bile ducts. Serum GGT level is a very sensitive indicator of obstruction. It is elevated in very early in any process that obstructs bile ducts or intrahepatic bile canaliculi. For the reference range, it varies between male and female. For the male, it's around 6 to 55 units per liter, and its females is 5 to 38 units per liter. Your 5' nucleotidase is an enzyme that is less commonly used for the detection of your cholestasis. There is no bone source of your 5-NT, so it's useful in differentiating ALP elevations due to liver from other conditions where ALP may be seen in increased concentration. So, increased in cholestatic disorders with no increase in activity in patients with bone disease. 5-nucleotidase can basically corroborate the elevation of ALP from a hepatic source.
So before we proceed to bilirubin determination, let's first give a short recap on the metabolism of bilirubin. Bilirubin starts off with the RBC as your hemoglobin. Hemoglobin, once broken down, turns into globin and heme. Heme gets converted into biliverdin, and finally into bilirubin 1 or your B1. B1 finds its associated transport protein, albumin, allowing it to be transported towards your liver. In the liver, it will undergo conjugation and finally be converted into your B2. This B2 is then excreted into your canaliculi.
So here is another diagram showing the metabolism of your bilirubin, starting with the RBCs, or rather the heme portion, forming unconjugated bilirubin, where it will then be carried by albumin towards the liver, where it will undergo conjugation, facilitated by your uridine glucuronyl transferase, and then it is excreted into the bile, converted into urobilinogen, and then it may be excreted in the feces in the form of stercobilin, in the urine as your urobilin, or it may re-enter into your enterohepatic circulation again.
So what's the difference between your B1 or your B2? So let's start off with B1. B1 is unconjugated. It is nonpolar, meaning it's water insoluble. That's why it needs your albumin or your carrier protein, generally referred to as your indirect bilirubin, and its other name is your hemobilirubin since it's found in your blood circulation. B2, on the other hand, is known as your conjugated bilirubin. It is polar, meaning it's water soluble, and it does not need a transport protein. B2 is also known as your direct bilirubin and your cholobilirubin because it's present in the liver and in post-liver. Some things to take note of when collecting specimens for bilirubin determination. So, bilirubin determinations generally used a diazotized sulfonilic acid solution, and this can be performed on either serum or plasma. In the case of determination methods utilizing your malloy-evelyn, serum is preferred. A fasting specimen is preferred as lipemia may increase bilirubin concentrations. Hemolyzed samples should also be avoided as they may decrease the reaction of bilirubin with the diazo reagent. Most important of all, bilirubin is very sensitive to and is destroyed by light. So take note of this when transporting or performing methods related to bilirubin determination. It should always be left protected from any light. If left unprotected from light, bilirubin values may decrease up to 30 to 50% per hour. If serum or plasma is separated from the cells and stored in the dark, it is stable for at least 2 days at room temperature, a week at 4 degrees centigrade, and indefinitely at negative 20 centigrade. For your bilirubin determination, initially we utilized a diazo reaction, in which we add your diazotized sulfonilic acid to your bilirubin sample, allowing us to measure conjugated bilirubin. However, as the years passed and technologies improved, the addition of an accelerator meant that we are now able to measure total bilirubin. Utilizing the additional accelerator are your Gendrasik graph and your malloy-evelyn procedures. The main difference between the two is the choice of accelerator preferred between each method. For Gendrasik graph, the preferred accelerator is your caffeine benzoate acetate, and the blue product produced is measured at 600 nanometers. In contrast, your malloy and evelyn utilizes 50% methanol as its accelerator, and its end product is a red-purple product measured at 560 nanometers. Between the two, malloy and evelyn is the more commonly used one in the laboratory.
Total serum bilirubin has a normal value of around 0.3 to 1 mg per dl in your adults. However, this may be higher in your neonates. It measures both conjugated and unconjugated bilirubin, and an elevated bilirubin can be an indication of liver disease, bile duct obstruction, or non-hepatic problems such as hemolysis. Sclera icterus, basically the yellowing of your eyes, it occurs when bilirubin is greater than 3.5 mg per dl. Your unconjugated bilirubin or your indirect bilirubin or B1 is the immediate product of heme breakdown. It has poor solubility and cannot be excreted in the urine and is transported by plasma proteins such as your albumin. Elevations are due to hemolysis, Gilbert's syndrome, drugs, and resorption of large hematomas. And lastly, your conjugated bilirubin or your direct bilirubin or bilirubin B2 has a normal value of less than 0.4 mg per dl. It has undergone glucuronidation in the liver to increase its solubility and facilitate its incretion. Conjugated bilirubin levels rise in bile duct obstruction, massive liver disease, either from severe acute injury or end-stage cirrhosis, does not significantly impair conjugation of bilirubin. Urine dipsticks for bilirubin and urobilinogen can be helpful in the workup of a jaundiced patient and constitute a quick but imprecise substitute for bilirubin fractionation and imaging of the bile ducts. In a jaundiced patient, the absence of urinary bilirubin indicates that the jaundice may be caused by indirect bilirubin. The absence of urinary urobilinogen indicates that the jaundice is due to complete obstruction of the common bile duct. So jaundice can either be prehepatic, intrahepatic, or posthepatic. For prehepatic, the most common causes are going to be hemolysis, for example, in your cases of G6PD deficiency, as well as ineffective erythropoiesis. For intrahepatic, it involves mainly the liver, so you have hepatitis, cirrhosis, and primary biliary cirrhosis, while posthepatic is mainly going to be due to obstructions, so you have your cholelithiasis, inflammations, malformation of the biliary tract, and tumors. So here is one way to differentiate between what causes the elevated bilirubin levels in your patients. For example, in your bile duct obstruction, which is representative of your post-hepatic jaundice. This is mainly going to be an increase in your direct bilirubin or your bilirubin B2. So you have a great increase in your urine bilirubin with normal urine urobilinogen. Unlike when you compare this to your prehepatic jaundice, your hemolytic disease in which urine bilirubin is negative, however, your urobilinogen in the urine is very elevated.
And that's my last slide. Thank you for listening and have a good day. Next, let's discuss about your pancreatic enzymes. Specifically, in this lecture, we're going to be focusing on your amylase and then your lipase. So before we proceed to the enzymes, let's give a brief definition on what a pancreas is. The pancreas functions as both an endocrine and an exocrine organ in control of your carbohydrate metabolism. It has two main purposes, as it has an exocrine function and an endocrine function. For its exocrine function, it produces and secretes amylase, responsible for the breakdown of the ingested complex carbohydrates. Further digestion leads to the production of your monosaccharides. As an endocrine gland, it is responsible for the secretion of your insulin, glucagon, somatostatin, and your pancreatic polypeptide. We're mainly going to be focusing on the exocrine aspect of your pancreas. First up is your amylase. Amylase catalyzes the hydrolysis of alpha-1,4 glucoside bonds in polysaccharides, yielding maltose and maltritose. There are two isoenzymes that exist. You have your P-amylase and your S-amylase. P-amylase is limited to the pancreas, while your S-amylase is found primarily in salivary glands, in your ovary and fallopian tubes, and in your small intestines, testes, and bronchial epithelium. Your amylase peaks in 20 to 30 hours and returns to normal after 48 to 72 hours. Avoid oxalate and citrate anticoagulants and instead use heparin. So the three main methods generally used to measure amylase are your amyloclastic method, in which we measure the disappearance of your starch substrate, your sacharogenic method, which measures the appearance of the product's specifically reduced substances, and your chromogenic method, which measures the increasing color from production of product coupled with a chromogenic dye. One condition that also produces an increase in your serum amylase and may be confused with your acute pancreatitis is macroamylasemia. It's present in around 1% of your populations and around 2.5% of patients with hyperamylasemia. Amylase is bound to an immunoglobulin, and the total serum amylase is elevated, while urine amylase levels are modestly decreased or normal. So decreased urinary amylase to urinary creatinine ratio may be useful in the diagnosis of macroamylasemia because renal clearance of macroamylase is decreased. So again, when trying to diagnose acute pancreatitis versus macroamylasemia, both will have increased serum amylase, as you can see on the first column there, with both showing high levels of serum amylase. However, when you take a look at the urinary amylase, you can see that only your pancreatic hyperamylasemia is high. And additionally, as I've mentioned in the previous slide, when comparing urinary amylase and creatinine ratio, pancreatic hyperamylasemia is high, while your macroamylasemia may be normal or low.
Your lipase catalyzes the hydrolysis of long-chain fatty acids at carbon 1 and 3 ester bonds, producing free fatty acid and monoglycerides. It is present primarily in the pancreas and absent in your salivary glands. For the reference range, it's less than 38 units per liter. Your lipase is superior to your total amylase and rises at around 4 to 8 hours and remains elevated to 8 to 14 days. This is also one of the benefits of your lipase, is that it rises far earlier and it remains elevated far longer when compared to your amylase. Prolonged serum lipase elevation suggests either a poor prognosis or development of pancreatic pseudocyst. Lipase is more specific to acute pancreatitis than amylase. The old method for measuring your lipase is your Cherry-Crandall method. It uses an olive oil substrate and then measures the liberated fatty acids by titration after a 24-hour incubation. Turbidimetric methods are simpler and more rapid than your titiometric assays. Fats in solution create a cloudy emulsion, so the rate of clearing is used as an estimate of the activity of your lipase. Colorimetric methods are based on coupled reaction with enzymes such as your peroxidase and glycerol kinase. And that is my last slide.
So up next, we'll be discussing your cardiac damage markers. So these are markers that help with the diagnosis of your myocardial infarction, with myocardial infarction being described as the death and necrosis of myocardial cells due to prolonged and irreversible ischemia. In order to diagnose our myocardial infarction, three items need to be classified as per the recommendation of your WHO. You need the clinical manifestations, the electrocardiogram or your ECG, and most importantly, what we're going to be discussing today, the biochemical markers. So first, let's describe the types of biochemical markers for myocardial infarctions. There are two main types we're going to be discussing today, the cardiac enzymes as well as the cardiac proteins. You can see there on the diagram on the right that each rises at a specific timing, as well as the level of maximum concentration peaks at various timings as well. Depending on this timing, we will be able to use certain markers more effectively than others. So up first is under the cardiac enzymes known as your total CK or creatine kinase, which is the sum of the isoenzymes of your creatine kinase, the MB, and BB. Take note that these are non-specific to cardiac tissues, as these are also available in muscles, and these begin to rise 24 hours after the onset of chest pain. Next is the CKMB or your CK2 activity. It's more specific than your total CK, however, it's still less specific than your troponin I because, as mentioned earlier, CKMB is found in your skeletal muscles. It appears in blood within 4 to 6 hours of the onset of the attack and peaks at around 12 to 24 hours, returning to normal within 2 to 3 days. One advantage is that it's useful for the early diagnosis of a myocardial infarction, as well as for the diagnosis of reinfarction. However, it's not used in delayed admission, those taking place more than 2 days, and it's not 100% specific, as it is also elevated in skeletal muscle damage. The third in your cardiac enzymes is your CKMB mass. It appears an hour earlier than your CKMB activity, making it more sensitive, and is generally used in diagnosis of early cases and reinfarction. However, it's not for the diagnosis of delayed admission cases, and again, it's still less specific than your troponin I. You have a relative index in which the CKMB mass divided by the total CK times 100. If this is more than 5%, this is indicative of your myocardial infarction.
Under your cardiac proteins is your myoglobin. Myoglobin is a cytosolic protein that is generally not specific for cardiac tissues, as it can also be found in skeletal muscles and renal tissues as well. It appears in blood earlier than other markers, around 1 to 4 hours, but it returns to normal within 24 hours. So it's not for delayed admission cases, especially in cases 1 day after the onset of attack. Next are your cardiac troponins. These are protein complexes located on the thin filament of striated muscles, and they consist of 3 subunits, your CTNT, CTNI, and your CTNC. TNI and your TNT are used as biomarkers for the diagnosis of your myocardial infarction. Cardiac troponins are different from skeletal muscle troponins because these are more specific for myocardial infarction diagnosis. Your troponin I or your CTNI is 100% cardiac specific, with greater sensitivity for diagnosing minor damage of your myocardial infarction. It appears in blood within 6 hours after the onset of infarction and peaks at around 24 hours. It disappears from blood after about 1 week and is useful for the diagnosis of your delayed admission cases. It can be used as a prognostic marker. And that is all for today. Thank you for listening and have a good day.